New addition to these talks, recognizing that we are all shifting out of what was assumedly a busy day, doing diverse things, clinical care, maybe having our own stresses, childcare, etc. I'm going to just take 1 minute and do a mindfulness exercise from Headspace. Hopefully we'll all do it together, and then we'll frame shift together into Intro to Geri Psych.
Hi, and welcome to Headspace. So no matter what's going on in your life right now, no matter how many thoughts are racing around your mind, no matter how the body's feeling, just take a moment to sit down and take a big deep breath, breathing in through the nose and out through the mouth. As you breathe in, a sense of taking in fresh air, the lungs expanding. As you breathe out, a sense of letting go of any stress in the body, in the mind, just feeling the muscles soften and relax. And close your eyes if you'd like to. One more, breathing deeply in through the nose and out through the mouth. And just take a moment to pause. Allow the thoughts to come and go. And then just gently opening the eyes again.
All right. Remarkable how effective a minute can be to bring you back to center. And all of our wellness is always important, but it's many times more important these days given the stressful world we live in. Please take time to take care of yourself. Quickly acknowledging our funding that we have from HRSA, both the group and myself. I have no conflicts of interest, and these are our standard acronyms that you might see during this talk. Most particularly, you might see BRIDGE, which is our Brooklyn Initiative to Develop Geriatrics Education. I might say the 4 M's, which I'll cover in just a second. And that's probably about all I'll say today. And just a reminder about the 4 M's, if you've been in our clinic, which many of you have been, or all of you have been, we are endeavoring to transform care to be more age-friendly, first here at Downstate and then with our partners throughout Brooklyn. And the 4 M's are really leveraging 4 areas of enormous potential for improvement within the House of Medicine. Particularly the most, I think, the largest areas for improvement amongst older adults. Mobility, right? How a patient or person is getting around safely and what assistance they might need to do so. Mentation, including memory, cognition, also dementia, depression, delirium. And medication, the use of age-friendly medicines that aren't going to harm a person's mentation or mobility, for instance, increased fall risk or increase the risk of delirium, and monitoring for polypharmacy. And of course, what matters, I saved this for last because it's perhaps the most important and the thing we forget the most. What matters to each patient and to their family in their healthcare? And how do we target our goals of care to best fit what matters most to that patient? Right, so I'll try to touch on these things as I step through this talk. This is a longer talk today, and it probably will we'll probably take a break at the halfway point and finish up around hopefully 4:30, and then the fellows and I and Dr. Prosper will go through a little bit of introduction to Journal Club. So before we go any further, and Cyan, if you're with us and could unmute everybody and allow them to talk. If you don't feel comfortable talking, please use the chat function and we'll go that way. What are the first things that come to your mind when you think about the assessment and diagnosis of older adults? I'm going to sit in uncomfortable silence until somebody speaks.
It's a long visit.
All right. So we heard it's a long visit. Certainly it can be.
Fear
Fear.
of the unknown.
Is that on the clinician side or is that on the patient side?
It could be a combination of both.
That's right.
Why is it important?
Right. Why is it important? And so some of the answers I get sometimes when I ask this question are overly complicated and time consuming, as it sounded like Dr. Lawrence said, or overwhelming, right? Handling all the problems, sometimes in a setting in which we don't have enough ancillary support or the interprofessional team that we need to handle that care. But I guess I urge you, as you're considering this question, to take a pause for the cause and consider your response to the older patient as you're entering into that room to assess them for the first time, or the second time, or the 100th time. Did you groan internally when you looked at how many problems co-occurring comorbidly that patient had? Or did you wish that your attending might take over because it was just a little too much? And think about checking your internal or implicit biases, monitoring for ageism, right? So that you can provide the best care for that person, and making sure your knowledge is in check so that you recognize what are the normal signs and symptoms that might come with aging, what is normal aging and what is pathological aging, so that you can differentiate them correctly and without implicit bias, treat what is treatable and leave things that are normal alone so that we don't cause harm by treating what is normal. So I like to start with a case, right? And did I set up the poll incorrectly? I did not. Oh, well, I may have added the poll to the wrong talk. Okay, so we're going to talk about Mrs. Young. Again, focused on geriatric psychiatry today. 67-year-old Caribbean American woman brought in to our clinic by her husband. Had become increasingly concerned about his wife's behavior, stating, "We need help. This is not my wife." "5 months ago, Mrs. Young retired from a long career in law enforcement. Over the intervening time, she had begun to experience progressive anxiety regarding her neighbors, eventually developing a belief that they had been surveilling her. The neighbors in question lived directly across the street from Mrs. Young and Mr. Young, and they had vehemently denied all surveillance. Very, very convincing. Mrs. Young had repeatedly confronted the neighbors, quite aggressively actually, regarding this belief, and had constructed her own counter surveillance apparatus. She hooked up video cameras and had binoculars and things. Really quite fixated on it. And the confluence of all these actions had led her neighbors to threaten legal action, a restraining order, which quite frankly in Brooklyn is tough. If you can't be within 50 feet of someone, your house is probably within 50 feet of that person, and may necessitate moving and other things, right? Tough times. So Mrs. Young also endorsed new difficulties with attention, handling some of her instrumental activities of daily living, and some mild depression symptoms that were worsening as the situation escalated. Oh, this is a repeat. So before we go any further, right, I had meant to insert a poll, but I seem to have perhaps inserted it into the 4 p.m. talk. What do we think about the diagnosis so far? Anybody that's willing to unmute and talk, go for it. Or if you feel free to put something into the chat.
Hi, this is Dr. Rashid. Could it be like a paranoid delusional disorder?
So like a delusional disorder, so a primary psychiatric illness, right? Thank you. What else? What do we think about the changes to attention and functional change? And the depression?
I'm a little out of my element here in making psychiatric assessments, but I'd certainly, if I were the nurse practitioner seeing her, I'd certainly want to get a psychiatric consultation with her. I also would wonder, are there any other underlying conditions that might result, before we do the psychiatric evaluation, that might result in these kinds of experiences?
Agreed. I would consider any underlying reversible medical problem, and also maybe the possibility of a brain lesion.
Right. So I think that sounded like Dr. Gerard and Dr. Prospier. Somehow I've lost my images of people. I don't want to spend time figuring out where they went. So we're missing some things at this point, right? But we should be developing a differential diagnosis, right? That has to follow a hierarchy, right? So first, could this be caused by this is a rather new onset condition, as far as we know right now, that could be explained by any number of conditions, some medical, some psychiatric, right? A psychotic disorder due to another medical condition, a sort of chronic delirium, a dementia, or something that is primary psychiatric, like a delusional disorder or major depressive disorder with psychotic features. And it deserves some careful thought, right, and careful assessment. And so this is speaking to Dr. Gerard's question, right, or comment. We need to know the history, which I've sort of withheld until this point. So past medical history, sort of relatively benign, presbycusis, glaucoma, hypertension, hyperlipidemia, and incontinence. Known admitted past psychiatric history, although that's, I guess, sometimes questionable. She's had cataracts removed, but no other major surgeries, and has a family history of both high blood pressure and a maternal history of Alzheimer's disease. And so now your brain should be kind of spinning about what's happening. Socially, a very nice woman. Born in Grenada, 3 siblings, 1 deceased. She's been married for 40 years. 3 kids, all living in the city, very supportive, college-educated woman, very bright, no adverse childhood events, and a retired police officer. Christian, attending church weekly, but doesn't attend a senior center, particularly the last 5 months. She's very engaged with her counter-surveillance operation. No real substance history. No cigarettes, rather. 1 to 3 glasses of wine per week, and standard glasses of wine, about 4 to 5 ounces. No drug use. Meds-wise, sort of very benign profile. Atorvastatin, timolol, latanoprost, and hydrochlorothiazide. So what's going on here, right? And what do we need to do next? I sort of did this brainstorm already, so I'm going to go past it. But we should be thinking, what's missing now, right? And what other history do we need? What other assessments do we need? So much like standard geriatric assessment. The psychiatric assessment of older adults has to be comprehensive. So I say C squared, because that includes a comprehensive history, physical, neuro exam, and targeted diagnostic testing, but also collateral informants when and if possible, and of course, if permitted by the person that you're treating. But I would argue a lot of times, particularly with new onset psychotic disorders, if you're not able to get the collateral history and in older adults, you're going to miss something important. And you have to remember that assessment is different in older age. We've covered this in many of our prior talks, but I want to reiterate that there's often communication difficulties. There can be vision and hearing deficits that you have to appropriately accommodate for. All of these things can be overcome in the clinical setting with adequate aids, right? In our clinic, when we're not operating virtually, we have hearing amplifiers for patients when they are unable to hear us fully to participate in our assessments. And we have all sorts of devices to sort of adapt to physical handicaps. Our scales are accessible, and we have wheelchair scales. And of course, cognitive difficulties, particularly in our clinic, which that's our primary area of focus. You have to be aware of medical comorbidities and in polypharmacy, age-related changes in pharmacokinetics and pharmacodynamics. Oh, there was a chat that I missed. Cyan is mentioning that there is a black box on my screen that I don't see. Are you guys seeing the black box?
Right, so it appears to be every time you open a chat or something on top of the screen you're sharing, we see it as a black box.
I see. So I've moved the chat out of the way. Is that better?
And we have one hanging right on top. I don't know what, do you have anything open, like a control menu? Yeah, this bar.
It's just the Zoom bar. I can move it over to the other screen. Thank you. Better?
Great. Yep.
Thank you.
All gone.
Yeah, thank you for telling me. I didn't know that. I thought the Zoom controls weren't shared. Interesting.
Yes, that's some glitch. It wasn't happening before.
I must have, I just did an update. Maybe my settings got lost. All right, anyway, and comorbid psych illnesses, particularly dementia and delirium, age-related changes in brain structure, and of course, the neurochemical changes associated with aging. These in particular impact our treatments, right? And when I see these, what's happening in the aging brain when it comes to some of the neurotransmitters? Anybody want to chime in? Dopamine, for instance. There's more dopamine or less dopamine? I haven't heard from many students today. You guys can do it. Come on. Cyan, does everybody have the ability to unmute?
Yes.
Okay. So of course there's age-related declines in dopamine production, dopamine receptor density, serotonin production, serotonin receptor density, and these things impact your treatment, right? They impact symptom profiles, and they impact how these diseases present in older adults. So when you are taking your history, the timeline is critical, right? You have to be aware of how recent onset conditions might present versus what are the conditions that might be longer in duration, right? So here we're at 5 months, and we're looking somewhere in this longer duration column, thinking about possible reasons that this person has developed psychosis. But you can't entirely rule out delirium. There are lingering deliriums that happen in older adults, and they deserve careful medical attention. We always talk about the 6 Ds of psychiatric disease in older adults. Delirium, which occurs over days to weeks. Drugs for days to months, and disease days to months as well. Depression, a little more chronically in the week to month spectrum, 2 weeks to months. And of course, dementia, which is more chronic, and delusional disorder, which is, and schizophrenia, which are, in many cases, lifetime illnesses. And you have to use objective measures, psychometric screening scales, which are followed by scales that are more specific to particular disorders after you've done the screening. Pair that with neuropsych testing to rule out cognitive disorders. And then you have to do these things serially to track the effect of treatment, or quite frankly, sometimes the lack thereof. So you know when things aren't going right and looking for signs of treatment resistance. You have to look for atypical features, right? Which suggests some other medical etiology, an unusual age of onset, absence of family history, absence of past psych history, like this patient. Although I would argue, given her cultural background and the inhibitions of folks from Grenadian culture, that perhaps sometimes family history is not of mental illness is not clearly reported. So it can be a little unclear in that regard. Limited response to your treatment, symptoms being more severe than you would expect for an illness, or symptoms that start after an abrupt personality change, and of course comorbid medical conditions that you know have an association with mental illness, and again abnormalities of cognition and consciousness. So this is a breakdown using an acronym MINE from a review article that Dr. Cohen and I wrote a couple years ago looking at common medical causes of psychosis in older persons. And I guess I would ask you whether, do you assess for all of these things when you have these patients, or do you do a targeted assessment of these things and at least consider, you know, an abbreviated or a partial differential? I know Dr. Prospeer often talks about, you use vitamins, Dr. Prospeer?
Correct.
Or vandalism? Which one do you use? I think the medical school uses vandalism.
Vitamins.
You like vitamins. I like vitamins too. It's a little more friendly. And this is just a partial list of the more common things that can cause psychosis in older adults. There's a whole textbook dedicated to this, just this topic actually. And you have to be mindful that while there's no consensus approach for the initial diagnostic testing of older adults with new onset mental illness or mental illness, most conditions seem to conduct what you see on the screen here, which is a combination of kind of standard metabolic screening, reversible causes of memory loss screening, and depression screening, and then augmenting with testing that fits the person's history, like autoimmune testing, HIV testing, toxicology, et cetera, neuroimaging, EEG, and polysomnography. And you will, if you've been in our clinic, you'll see that we do some or all of these things for each person. It depends on what's happening and whether there are atypical features that guide us to running those extra tests. Let's go back to Mrs. Young. So patient and her husband both endorsed, she didn't really like to admit to much in the way of symptoms, but she did endorse a long history of increased vigilance. She kind of called this a healthy paranoia. Particularly regarding threats to the safety of their family. They both described this sort of to her line of work, right? She was in the police office, or the NYPD rather, and was concerned that her work might follow her home. And this vigilance became a lot more pronounced after joining the police department. And it had never impaired her work or her home life though. But over the past, so we're getting a little sense of the chronicity of some, not personality traits, some proclivity towards paranoia earlier in life. But over the past 5 months, she's getting much more paranoid and preoccupied by her delusion, entirely ignoring her obligations, sometimes while obsessing over the neighbor's surveillance. And so here, I mean, so that initial complaint of deficits in day-to-day function had more to do with this rather than a decrement in her ability, right? She was so focused on the counter surveillance that she couldn't see to her day-to-day life. She didn't have hallucinations, but did kind of had some illusions, perhaps. I see the glint of the binoculars in their window. And she kept saying this during the assessment, trying to convince us that this was the case. No mania, no panic. So we did our psych review of systems, right? No generalized worry, tension, obsession, or compulsion, but did have some problems with focus and difficulty handling her daily affairs, like we mentioned. And over the past month, she'd also begun to complain of more depression. I just keep trying to keep them safe. Why don't they believe me? And this was heartbreaking for her because she thought she was helping her family. And they didn't see it. No suicidal ideation, no plan, but she did have access to a handgun, licensed. So we did our, risk assessment, and we made note of that. And we went on to do a physical exam after we collected that history. Mildly overweight, nothing too concerning. Normal cranial nerve function, no focal weakness, no tremor, no gait, no abnormalities. So we were looking at other causes of psychosis here, right? Is there any sign of focal abnormality that would make us think stroke? Any signs of Lewy body or Parkinson's disease? Not so much. Or something less common like normal pressure hydrocephalus? Not so much here. And we went on to do a mental status exam, right? Fully oriented, so we think not delirious, perhaps, pleasant, well-related, overweight but neatly groomed, cooperative, no psychomotor abnormalities, right? So no stereotypy, no pacing, no tremor, etc. Maintained eye contact, and her speech was quite normal. Mood, however, was stressed, and her affect was a little sad. Her thought process was goal-directed, linear, but really her thought content was very significant for this persecutory delusion. No other delusions, right, that might lead us towards another type of diagnosis. No thought broadcasting or insertion, no suicidality, as we mentioned, no hallucinations in any modality. And really didn't have much in the way of insight regarding her condition. We anosognosia, which is very common in primary psychotic disorders. So perhaps we're leaning more in that direction at this point. We went on to do a cognitive exam, just like I'm telling you we should do. She had some mild impairments in attention and working memory, with normal performance in all other domains, including short-term memory, visuospatial function, abstraction, praxis, and executive function. So we see these findings, though, in lots of mental health conditions, right? There's working memory and attention impairment in lots of things, kind of non-specific, but certainly she doesn't meet criteria for dementia with this exam, right? So when I say mild, we're talking about 1 to 1.5 standard deviations away from normal. And we did a Hamilton Depression Rating Scale, a psychometric test for the more specific symptom that she had, which was depression beyond the delusion. And so she got an 8, which is just into mild depression. Normal is 1 to 7, 8 is mild depression. And we did labs, which were remarkably unremarkable. MRI, which was sort of very common panel of findings for her age. Periventricular white matter changes, very common in older adults, and very age-related volume changes without differential atrophy. And so we're looking for differential atrophy to look for more specific signs of, say, Alzheimer's, right? She has cognitive complaints, she got psychosis. It's actually much more common that it might be Alzheimer's than something else. Delusional disorder and schizophrenia are fairly infrequent diagnoses. So what do we think now? I've been narrating my thought process as I go through. Any additional thoughts? And I see Dr. Gerard has asked whether this assessment was done during the pandemic, and it was not. This is pre-pandemic.
That's good. I raised that question because I thought probably there's a lot of us who are feeling paranoid and depressed and anxious.
Sorry to laugh. That's right. That's
You don't. I speak for myself, of course.
That's a good point. I didn't modify this presentation to address the pandemic. But you're absolutely right. This assessment was done a little over a year and a half ago. So any additional thoughts about her differential or where we're landing so far? quiet group today.
Hi, this is Dr. O'Mary.
Hi.
I would like to learn a little bit more about the depressive symptoms and if they have been present really only with the delusions, or if they've been present without the delusions. Did she have a longer history of the depression? And so I could kind of parse apart things like schizoaffective versus concomitant disorders of depression. And
yeah, so right. So that's a perfect question. So in this case, the depression started after the delusions had started, and at least as reported by the family, were almost exclusively tied to the stress that the patient was experiencing and the denial of her family in believing her. And the depression does evolve in this case. We'll talk a bit more about that, but so it's important, as Dr. O'Mary is noting, to ask this question and to get the timeline, because depression is very frequently comorbid with many psychiatric illnesses, which can be very stressful for patients and their families. But it can also be a feature of specific illnesses like schizoaffective disorder. So you have to know that. Thank you. And there was no, to the best of our knowledge, no pre-existing history of depression. That was your other question.
Yeah, so that kind of makes me lean towards schizoaffective disorder as at the top of my differential.
Okay, so somewhere in the primary psychotic disorder realm, right?
Yes.
Okay. So let's step back and just revisit the complexity of older adults, right? And I talk about this a lot, but I really want to emphasize that, you know, when we start off in life, we actually are very similar, right? When we're kids, and as we move through life, we become increasingly complex, and older adults are actually the most heterogeneous group in the population. We move through life collecting diverse educational, occupational, environmental, and social exposures, right, that change us as compared to our age-matched peers. And so it's important to remember and not just chronologically age someone, but also age someone based on their actual biologic age. What have they experienced? Have they led a very difficult, stressful life, as many chronic schizophrenics might? Or have they have a very healthful life that where they really monitored their health and took care of themselves over time? And they might be biologically aged earlier than or younger than their chronologic age. So it's important to really assess each individual as truly an individual, but also consider them within their age-matched cohort. There are a lot of shared common life experiences that may have psychosocial ramifications. We call these cohort effects. And so there used to be a smaller number of cohorts, but as older adults are living longer and longer globally and in the United States, there are an increasing number of cohorts within the aging population. So we know that, for instance, folks born before 1930 or who were born during the Great Depression and came of age during World War II will be kind of remarkably different in their life stance as those born after the war who came of age during kind of more prosperous times that included cultural revolutions, the civil rights movement, etc. The oldest African Americans grew up during periods of marked racial segregation and discrimination, which we're seeing haven't entirely or really faded anywhere near as much as we wanted them to. Whereas the young old African Americans came of age during the civil rights movement and the Black Power movements and are more free and willing to talk about differences of opinion and speak up for themselves when engaging with healthcare. The oldest African Americans might be more deferential to you in your treatment. So you have to use a person's history, individual and cultural, at the time period in which they lived to provide a context from which to stage your evaluation. And remember that the population is growing more diverse. In 2000, only 16% of the population was non-white, but in 2050, we're going to eke up to about 36% or higher. I didn't update that percentage this year, but remarkably, our population is diversifying despite our politicians, our current leadership's intentions to the contrary. And I would argue this is the strength of our country, right? This is what makes this a cool place to live. So you have to be expecting to work with diverse people, and you have to prepare yourself to do this. You have to know the cultural idioms, the cultural context of the individual patients you're treating, and you have to understand how that will impact your treatment, how different cultures will approach care, interact with you as physicians, and so that you can learn those things and deliver competent, person-centered care, deliver what matters to the patient, to the older adult in this case. All right. And you have to remember that disorders may present differently, right? Like physical disorders, clinical presentations of psych disorders in older life differ, right? Even though, and this is really important, even though the DSM-5 criteria are the same, right? So you have to have some pre-knowledge of how older adults may look to you. So major depression-wise, we know that there's more psychomotor disturbances, either agitation or retardation, which means kind of slowing down of movement. Less sadness, but more planning dysfunction, executive dysfunction, and more melancholy, which means kind of withdrawal, slowing of movement or pacing, and more weight loss, loss of interest, social withdrawal, irritability, and more somatization. Which we also see a lot in kids, but less so in younger adults and middle-aged adults. And you have to be aware that there are subtypes of depression, right? So that you're considering all of this when you're stratifying the patient's treatment and being so that you can understand the prognosis and adequately articulate that to your patients. Vascular depression, depression with due to vascular lesions, stroke lesions, is more common in late onset disease. And so periventricular white matter hyperintensities like this patient has, deep matter hyperintensities. Overall, we think that this vascular depression entity is caused by a disruption of the prefrontal systems, which in part perhaps explains why there are more neurovegetative symptoms, psychomotor changes, somatization, and also melancholy, right? More apathy, psychomotor changes, and less psychoses, less family history, less guilt, less insight. And so let's turn now to schizophrenia, right? This differs as well. And this third column on the right should say late onset schizophrenia. I seem to have accidentally deleted the header. So there are, of course, a broad spread of schizophrenia presentations, and schizophrenia is not only a disease of the young, right? Early onset schizophrenia occurs before the age of 40 and continues on into late life. And late onset schizophrenia occurs after the age of 40 and accounts for 15 to 20% of cases. There's an additional entity that is very specific, I think, to those of us in the field. It's called very late onset schizophrenia, like psychosis, that occurs after the age of 60. But we're all quite not sure what diagnostic category that actually falls under. But early onset schizophrenia versus late onset schizophrenia, late onset schizophrenia is more likely to have persecutory delusion, visual hallucination, or multimodal hallucinations like visual, olfactory, and tactile than those with early onset. Much less thought disorder and much less negative symptoms like affective blunting, and more sensory impairment, which kind of comes with the territory. And there's a switch in gender predisposition. In late onset schizophrenia, there's a much higher prevalence in women as opposed to men. And of course, the medication dosage, as we said earlier in this talk, is the requirements are much lower, both for older adults in general and in particular for folks with late onset schizophrenia. So there's a diminution, a decrease in positive symptoms with age, but levels of co-occurring depression may remain the same or even increase. There's a certain difficulty that folks with late onset schizophrenia experience with the onset of illness, as they've had a more normal life course up until that point and acutely feel the loss of their normal life, and consequently develop depression. And mild cognitive problems that may be presented earlier in life may worsen due to normal effects of aging. So there's this interesting literature here. When people suffer the onset of schizophrenia, there is a concomitant decline in cognition, which is fairly predictable, but after the onset of schizophrenia, that decline is fairly stable. It's in most individuals, there's not a progression of cognitive decline until you reach later life. And then because there's been a loss of neurologic reserve, perhaps then folks with schizophrenia might slide into dementia a little earlier than their age-matched peers, but the rate of change is not different than anyone else. There is a subgroup of folks with schizophrenia that probably have a more progressive course of cognitive decline. These tend to be the sickest of the sick, right? Folks that have been in a state hospital their whole life, and have had little social interaction, little cognitive stimulation. They seem to decline quite rapidly, and this is an area of study. So clinically, right, what does this mean for us? So when you're treating older adults, you have to determine the subtype of illness when it comes to depression, because prognosis varies, right? Non-vascular depression has a better prognosis than vascular depression. Treatment intensity may vary, dosage needs may vary, and we'll talk about these individual illnesses in later talks. I don't have enough time to go through them all today. And when you're treating people with schizophrenia, you need to be aware that changes in symptoms happen with aging, and you have to adjust your treatment accordingly as their brains age. And so you have to remember that aging is characterized by both long-standing conditions and late onset conditions that may become chronic. Depression, unfortunately, in older adults is often chronic. Greater than half of persons with clinical depression in late life remain syndromally depressed. An additional 30%, so of the people that recover, 30% have residual symptoms, subsyndromal or subthreshold depression. And even under ideal perfect treatment conditions, up to about a third of older people with new onset depression relapse on 2-year follow-up. 2/3 relapse without medications. So our treatment does make a difference, but the outcomes have not been as positive as we would like, and this is an area really where we have room for improvement. Hopefully some of you will become geriatric psychiatrists and work to research new compounds, new treatment modalities, psychotherapy modalities that will help get us a little closer to 100% better. And the line between reversible and irreversible becomes less distinct. Late onset depression may, of course, as we know, be a prodrome of dementia. And other conditions, including delusional disorder, actually seem to increase the risk of developing dementia later in life. It's estimated that about 40% of late onset depression, so depression that occurs in older adults for the first time, is accompanied by some cognitive problems. We call it pseudodementia, which may eventually progress to real dementia, despite adequate and complete resolution of the original complaint, which was depression. And of course, for clear reasons, people with vascular depression are more likely to develop dementia because of the loss of neurologic reserve. And I see Dr. O'Mara's question. When I say syndromally depressed, I mean people meeting diagnostic criteria for depression. That's absolutely right. So And these things aren't occurring in isolation, right? Mrs. Young, in this case, is sort of remarkably healthy with relatively few comorbidities, but all older adults with psych disorders have comorbid conditions, and the interaction between those conditions really can impact that person's functionality and quality of life. And we have to consider this person in its totality. So clearly, some comorbidities really cause substantial disability and functional decline, osteoarthritis, heart disease, dementia, etc., while others have less so. So depression, and we'll talk, I have a mood disorders talk coming up sometime this month or next, results in higher occurrences of certain physical illnesses. Physical disorders may increase the levels of depression and vice versa, and there's mortality rates go up in many conditions when depression is comorbid. MI patients, for example, have a fourfold increase in mortality post-MI when they have comorbid depression. And about 1/4 of persons with medical illnesses, particularly severe medical illnesses, have clinical depression. This is why in primary care, like Dr. O'Mary, so Dr. Emanuel is asking whether cyclothymic is subsyndromal. Cyclothymic is a separate illness, actually. We could talk more about that maybe in the mood disorders talk. Yeah. And of course, psychiatric illnesses are often comorbid with themselves, right? Depression is often comorbid with anxiety, especially in older adults. And anxiety is a poor prognostic indicator in depression. So one of the more common health challenges we see, especially here in Brooklyn, is a combination of all of these things together. All right, you have an older adult who has chronic pain, which is itself depressing, has cognitive impairment overlaid on depression and anxiety regarding their fear of falls, their loss of loved ones, the bereavement that they've experienced over their life, the loss of their early life friends and family members, spouses, partners, and the social isolation that occurs. And of course, and especially in our community, we live in a food desert, the lack of food security, lack of adequate access to good, nutritious food. So we know that there's some evidence that treating depression can improve health outcomes and that improving physical health can improve depression and anxiety, but you have to do these things together. Unfortunately, our treatments for depression in older adults with concomitant physical disorders have less robust outcomes. It's sort of a mixed picture, which can be very frustrating. So, and again, all of this has to be considered within that social, psychosocial and biological context, as we discussed earlier in this talk. When you're assessing that person, you have to take a real stock of the material and emotional resources that person has in addition to their physiologic conditions. It's said that aging is a bit like gambling. The longer you go on, the more you are likely to lose. I'm normally a very optimistic person, but I'm using this quote on purpose and to make a point that you have to assess for these things when you're with older adults. And we might talk about the 4 Ds of aging, like 6 Ds of psychiatric or psychosis in older adults, the 4 Ds of aging, which focus on losses that can be expected when you're treating older adults and will affect their psychiatric state and their physical health state: disability, dependency, desertion, and of course, death. So when you're treating all of these people, you have to take into consideration the confluence of all of their conditions and their psychosocial milieu, and suggest things that are both physically and socially, for adults who have more physical and social resources. You might encourage increased activities and engagement, right? We do this all the time in our clinic when we introduce targeted physical and social activity to improve outcomes, especially when there has been loss, right? Personal, social, family loss, and to target their underlying psychiatric condition. However, you really have to know your patient, right? Person-centered care, what matters to that patient. You have to take into consideration their disabilities, and if they have fewer resources, if they have more disability, if you encourage a program of care that is overly optimistic and overly realistic, or is unrealistic, you might exacerbate that person's condition and actually make them feel more worthless and more depressed. So you need to work with the person and the family to target and titrate the intervention that you're giving so that you can make a positive impact instead of hurting that person. And of course, the prevalence of psychiatric disorders in older adults is also best considered on a continuum, right? And considered in the confluence of our society. And it may be underestimated. To give you an idea of the scope of the problem, right? So official psychiatric disorders probably do not accurately reflect the real distress of mental health conditions in our aging community. Older adults present atypically, and so when they do these large national comorbidity studies, cohort studies, they, for many reasons, sometimes miss older adults in their modality of study, or their screening instruments may not adequately capture the suffering that older adult is experiencing. And of course, comorbid physical and cognitive disorders often have symptoms that cross each other. They may have symptoms in common, making the fulfillment of the diagnostic criteria more difficult. So you have to view these illnesses on a continuum and look at subsyndromal and subthreshold disorders as well. And when I say subsyndromal, I mean conditions that do not meet full diagnostic criteria across the spectrum of those illnesses, whether we're talking about mood illnesses, mood spectrum illnesses, or psychotic spectrum illnesses. Or anxiety or neurocognitive disorders. And remember that when you're doing these studies or considering your population that you're treating, elders particularly with psychiatric distress may be clustering in certain settings, like NORCs, naturally occurring retirement communities, assisted living facilities, and nursing homes, resulting in an overall underestimate of the prevalence of psychiatric illness in these populations because of inadequate sampling. So I gave that preamble, I think, so that you take these next few slides with a grain of salt. But before we go on, I'm going to take a couple-minute pause for the cause to give everybody a second to stand up and move around. We'll come back at like 4:03. Okay? All right. So let's continue our tour of prevalences. So welcome back. I'll give everyone a second to rejoin. Someone who's able to speak, you can all hear me again. I making sure there's no glitch.
Can hear you.
Thank you. And so Dr. O'Mary is asking an important question that she's seen that her prescribers in her experience have been more likely to treat mental health conditions in late life with medications rather than psychotherapy. Is there a data-driven reason for this? And I would say no. The data for this is quite to the contrary. Much like in younger adults, psychotherapy, especially in mild to moderate depression, should be first line, and moderate to severe depression, for instance, should use a combination of meds and psychotherapy. And in most of our conditions, the evidence is that combined therapy is the way to go, is kind of the gold standard. I will say that during the pandemic, when we have had less access to people and there has been a decreased access to psychotherapy, perhaps owing to increased demand, there probably has been an increased use of medications, even in our clinic where we try not to do this. Just recognizing the situation and the need to provide treatment and the desire of our patients to be treated. But no, absolutely you should use psychotherapy. There's only 2 real contraindications for psychotherapy, just as a reminder for everybody. One is active intoxication, right? If you're actively intoxicated, you're very unlikely to benefit from therapy. For any of us that have ever spoken to an intoxicated patient in the ER, you will understand why. And the other is probably more than mild dementia, right? And that deserves a little qualification that we could talk about later if anyone's interested. It kind of depends on what kind of dementia and where the particular deficits are. But in more than mild dementia, psychotherapy is actually harmful rather than helpful because you're sort of bringing up harmful memories. And sort of the way Alzheimer's, for instance, works, like the affective centers of the brain are healthy much later into the illness. So you bring up in therapy, you bring up a difficult memory, you bring up the negative emotion that goes with it, but the sort of semantic memory of what you discussed as the person leaves therapy they don't remember what you talked about, but the emotions are still there. So they can't process what happened and they're left with a negative emotional state that they don't know what to do with, and you worsen their behavior quite a bit and their outcomes. It's not nice. I hope I answered your question. I probably went on a longer tangent than I intended. If you
I really appreciated it, even if it wasn't what you intended.
Thank you. So just a quick overview of prevalences of conditions, right? And I point these out because in part, they don't probably represent what you think of happening in older adults, and it actually looks more optimistic. But again, it doesn't capture everything. And so the 12-month prevalence of DSM criteria depression, major depressive disorder for people 55 plus is about 4.9%. But there's a steady decline in prevalence as you get older, and there's sort of a survivor effect. Folks that live into their 80s tend to be more optimistic, more resilient, and suffer from less depression. This does, of course, not capture that subsyndromally depressed group that I was talking about earlier. And so it behooves you as clinicians to even when the person is not having full syndromal depression and might benefit from talk therapy for subsyndromal depression, that you give them access to that treatment so that they can be as healthy as they can be. Clicking the wrong thing. Anxiety disorder seems to follow a different pattern, though. Anxiety disorders are perhaps the most prevalent condition in late life mental health, as far as late life mental health disorders go. And you can see that they kind of drop as we're moving into our 70s and then start to uptick again as some specific phobias crop up, particularly like fear of falling. But the anxiety disorders in particular are understudied in older adults, and again, grain of salt with this data. So just by comparison, right, the 12-month prevalence for any mood disorder or anxiety disorder was 9.5% for mood and 18.1% respectively for anxiety disorders. And so not much higher rates in younger versus older patients. In all age groups, MDD was the most common mood disorder, and specific phobia was the most common anxiety disorder in these studies, these catchment area studies. But if you use subsyndromal categories to capture these things, you get much higher rates, right? Subsyndromal depression, based on meeting symptom prevalence and severity criteria, is about 12%, maybe as high as 24%. So that's about a third of older adults may meet criteria for syndromal or subsyndromal depression when you put them together. Sorry, I read that initial blurb wrong. So the 12% is for full syndromal depression, and subsyndromal depression is around 24%. And together, summatively, you can have about a third of older adults at some point in their late life having syndromal or subsyndromal depression. And of course, the prevalence of depression is much higher in people that are medically ill, especially acutely medically ill. And syndromal and subsyndromal anxiety may be found in slightly over 15% of the older population. Oops. This is important, and I want to say this again. I think I've said it like 3 times, but I'm going to say it one more time, because subsyndromal depression and anxiety disorders are associated with higher rates of functional impairment, disability, medical illness, and mortality, right? Find these things and treat them. These QI movements for integrated care and primary care are really important. You're really going to help people by uncovering their depression and anxiety and adequately treating it. And of course, their cognition and psychosis. Psychosis is even tougher than anxiety and depression. So the gold standard study that we all use to quote, that we all quote for prevalences of these conditions, the epidemiologic catchment area study, found only about 0.3% of people with age 65 and over who have schizophrenia. And the National Comorbidity Study, another gold standard study, didn't really provide enough data on older adults to make a statement on this, but the general population on a whole, all age groups, was found to have a 1.5% lifetime prevalence of psychosis. But if you view psychosis on a continuum, right, meaning not just syndromal psychotic disorders like schizophrenia or delusional disorder, but the presence of symptoms of psychosis, the prevalence in the general population is actually about 11%. So that's like over 7 times the lifetime prevalence of the formal diagnostic categories for psychotic illnesses. And dementia is, of course, extraordinarily prevalent. So I normally spend more time on this, but in the interest of time, since we do have a full hour on, actually full 6 hours on various dementias, I am going to move quickly through the prevalences of the dementias. I'm happy to go back to it later or share this slide set with anyone that wants them. But of course, we know that Alzheimer's disease is I guess, by most standards, the most common dementing illness, major neurocognitive disorder, followed by vascular and mixed. In our population, it's probably mixed, though. Upwards of up to 40% of cases, certainly that we see in our clinic, but by objective measure as well, are mixed, particularly Alzheimer's and vascular, or Alzheimer's, Lewy body, or all three together. And this is again followed by Lewy body and pseudodementia, and then followed by other subtypes of dementia and less common things. And I should have hid this slide. And there are, of course, various degrees of cognitive impairment that contribute to neuropsychiatric symptoms in late life and are worthy of your attention. That includes mild neurocognitive disorder, up to about 10% of people 70 to 79 and 20% in those 80 to 89. And this is the overall splay of where things lie in simple tabular form, right? Anxiety disorders are the most common 12-month prevalence diagnostic disorder in older adults age 65 plus in the sort of mental health field, followed by dementia, depression, dysthymia, alcohol abuse / dependence, schizophrenia, bipolar, and anything else. So you have to view treatment goals for older adults with severe mental illness in the context of their life course and trajectory. And remember that understanding simple prevalences and symptom profiles isn't enough. You have to understand that many of these illnesses have relapsing and remitting courses. And schizophrenia is one of these. It doesn't have a quiescent end state. Nearly half of people, very positively, may attain social recovery, but that means that half haven't, right? Up to a quarter may have persistent remission, but the other folks are going through cycles of relapsing and remitting illness. And depression outcomes are sort of similar. About half continue to have clinical depression on follow-up, and perhaps 30% have appreciable residual symptoms, as we mentioned earlier. So the best way to consider older adults' outcomes across the lifespan, particularly people with syndromal mental illness, right, or severe mental illness, the ideal life trajectory might be considered as moving from severe illness, moving towards a state of diminishing psychopathology and decreased or improved functioning. And you have to be moving towards a normalization and towards positive health and well-being. And this last area, little blurb, hits it best. We're moving from a state of psychopathology towards community integration and successful aging. And your job as a clinician is to understand the context that person has come from, cultural, social, occupational, et cetera, their current psychiatric symptoms, subsyndromal or syndromal, their medical comorbidities, to move that into a cohesive picture, both for you and the patient, so that you can make sense of it together, and then develop a treatment plan that is individualized to that person, right? Targeted with physical, social, medication, psychotherapeutic techniques for that individual so that they can move towards a state of successful aging and attain their individual goals of care, what matters to that patient, right? We've talked about this quite a bit. And you have to recognize that many disorders overlap with respect to neuropathology and symptoms, particularly when it comes to dementia, right? Depression overlaps frequently with psychosis and with dementia. Depression may be a prodrome of dementia. Movement disorders overlap with psychosis and dementia, right? As we move across the Parkinson's disease plus dementia, Lewy body, et cetera. And all of this can be worsened and impacted by other medical conditions and pharmacotherapy and polypharmacy. I call this the Venn diagram of geriatric psychiatry. Everything interacts with everything else, and it is our job to pick this apart and find the way to treat the person on an individualized level. right? For example, right, in Alzheimer's disease, right, we often think of dementia just as a disorder of cognition, but it very frequently has associated neuropsychiatric symptoms. Up to 24% of community dwelling folks have hallucinations, or up to a half have delusions, and many have mood disorders. Parkinson's disease and dementia with Lewy bodies and Parkinson's disease plus dementia also has remarkable prevalence of hallucinations, up to a quarter of Parkinson's disease patients, half of Lewy body patients, and 3/4 of PDD patients. And I point this out, I always point this out for when I give this talk, you know, when we take tests about dementia with Lewy bodies, everybody has visual hallucinations. This is the thing that triggers us to make that diagnosis. There might be some other associated symptoms like REM sleep behavior disturbances, etc., rigidity, but the visual hallucinations is the buzzword. But only half of patients with this condition have visual hallucinations. You have to take the full history and run them against standardized criteria to make the diagnosis, because those hallucinations occur in other conditions like Parkinson's and Alzheimer's disease. You got to do the full job. In Parkinson's, up to half have depression and a third have anxiety disorders. And depression may precede motor dysfunction in a large percentage of these people. So because symptoms and pathology overlap, you have to get the good history. You have to conduct the comprehensive evaluation to determine the diagnosis. You cannot jump to a conclusion about a patient. And it seems like we didn't do that today, which is great, right? Older adults are complicated. There's a complex interaction between age and mental illness, and between their mental health condition and their physical illnesses, cognition, personality, psychosocial milieu, and financial status, and life stress. And there's multiple stressful events that have happened to an older adult in their life that you have to account for. And despite this, not all older adults develop psychiatric disturbances, right? We have to really recognize that many older adults are survivors, right? And when you have a survivor in front of you, acknowledge their strengths, acknowledge their accomplishments and their ability to handle what's happening. It can be quite remarkable. I love talking to older patients. I've covered this already. Love this picture. Older adults are survivors. I'm going to say it one more time. They've survived and outlived their age-matched peers in many cases, especially the oldest old. And they have strengths that you have to recognize, along with any shortcomings that you're going to work to overcome. So back to Mrs. Young. So Mrs. Young's symptoms were causing a decrement in her social functioning, and had begun to have legal ramifications. So she's meeting dysfunctional criteria for primary psychiatric illness at this point. She doesn't have any physical conditions to our knowledge that are impacting or causing her psychiatric presentation. None of her medications, to my knowledge, when taken appropriately, should cause her psychiatric presentation. And there was nothing on physical exam, cognitive panel, or neurologic exam that would indicate that this was the result of either a dementing illness or other metabolic or physical condition. So the diagnosis that we landed on in this case was delusional disorder, actually, given the time frame of illness, despite the comorbid depression, which I know Dr. O'Mary picked up on. We landed initially on delusional disorder. And we wanted to give her medication because her condition was really too much for psychotherapy alone, we thought. But her anosognosia was strong. She did not believe she had an illness. And we have to meet the person where they are and understand what matters to her. So after a lot of talk and psychoeducation, and quite frankly, the demands of her family and her legal team, her lawyers got involved, the patient acquiesced and went to psychotherapy. So she went to CBT for psychosis, hopefully to develop insight into her condition. And so she went for 6 weeks, and she did actually quite a bit better. We use the CGI improvement scale to measure this. It's a clinician assessment measure. It's not perfect, but it's the simplest tool to use. But then she had a setback. So she, unfortunately, things did not go well. Her neighbors did not relent in their legal case. And over the next 4 weeks, she began to get really depressed and was brought back into us. And so she was screened again with the Hamilton Depression Rating Scale, and now she was at a 36. So this is severe depression. She'd become hopeless and had begun to contemplate suicide and had thought about ending her life with that handgun. Her persecutory delusion came back in full force. And so Mrs. Young was viewing her suspicions as sort of confirmed by the lawsuit's outcome. So any insight she'd gained was completely smashed by this lawsuit. It was very devastating. And so her condition at this point, of course, necessitated emergent hospital stay, particularly given the imminent threat to her own safety and potentially her family's. We don't know. So she was admitted and was started on an atypical antipsychotic and an antidepressant, risperidone in this case, which perhaps has some of the stronger evidence for its use in delusional disorder, and escitalopram, Lexapro. And she did quite okay. She was discharged after 14 days, improved, without further suicidal ideation or plan. Not perfect, but better. And her family and the patient agreed to turn in the handgun. This took a bit of discussion, but we got there. And over the next 7 years, she had multiple other recurrences of her, two further recurrences of her illness, which necessitated brief increases in risperidone dosage and booster sessions of CBT for psychosis. I know I said that this assessment was based on something that we did a year and a half ago, but I think that was the last time that we saw her. We had a longer course of history for her. She also suffered, unfortunately, from further recurrences of major depression surrounding each episode. It didn't come before, it sort of came along after as she was taking stock of her life and what this illness had been doing to her. And then unfortunately, really unfortunately, at the age of 75, she began to suffer from increasing deficits in short-term memory and was eventually diagnosed with Alzheimer's disease. And so I chose this case, not certainly because it's uplifting, but because it really typifies what happens in our clinic. Our illnesses they require comprehensive diagnostic assessment and full utilization of the family unit for treatment, psychotherapy, plus medications. The courses have relapsing and remitting natures, and perhaps due in part to the predisposition or the loss of neurologic reserve that occurs in some of these illnesses, like schizophrenia and delusional disorder, the threshold for reaching Alzheimer's disease is lowered, and we get there. She didn't get there terribly young. She got there within late onset Alzheimer's disease sort of diagnostic category, but she still got there despite the fact that we had hoped that she wouldn't. She also had biologic loading from her mom. Okay, so I finished up in almost exactly 90 minutes, which is what I promised you guys. Were there any questions? Thank you, by the way.